The strategic medical reserve management systems across Western Europe operated within their normal inventory parameters. On May 18, 2024, logistics coordinators monitored stockpile databases tracking emergency medical supplies maintained for pandemic response, mass casualty events, and healthcare system surges. Warehouses in France, Germany, Spain, and Italy stored 340 million units of personal protective equipment, 89 million doses of essential medications, 14,000 ventilators, and critical medical devices worth approximately 4.7 billion euros. Automated inventory systems tracked stock levels, expiration dates, and distribution protocols. GPS tracking monitored transport of supplies during emergency deployments. Nothing indicated that database records were being systematically falsified through carefully targeted data manipulation. The first indication appeared as a minor inventory discrepancy that seemed routine enough to attribute to clerical error. At 06:17 UTC, a warehouse manager in Lyon noticed that database records showed 470,000 N95 respirator masks in storage location B47, but physical inventory counted only 470 masks, a 1,000-fold discrepancy. The error remained well within the variance expected from data entry mistakes in systems managing millions of inventory items. The manager who identified the mismatch assumed a decimal point error during database entry, manually corrected the record to match physical count, and filed a routine data quality report. The system accepted the correction without triggering alerts. The incident closed as standard database maintenance requiring no investigation. But the inventory falsification was systematic. Over the next 31 hours, similar discrepancies appeared across strategic reserve systems in 4 countries. Ventilator counts in German warehouses showed unexplained inflation. Medication inventory in Spanish facilities logged phantom stock quantities. Medical device tracking in Italian storage sites displayed location errors, placing critical equipment in non-existent warehouses. Each event appeared isolated. Different facilities, different supply categories, different inventory management systems from different software vendors. The incidents remained below thresholds that would trigger coordinated investigation because strategic reserves operated through separate national healthcare authorities with independent oversight. At 13:23 UTC the following day, the pattern became impossible to ignore. 64 strategic reserve facilities simultaneously discovered that their inventory databases had been systematically corrupted with false stock quantities, incorrect locations, and fabricated expiration dates. The data manipulation appeared in coordinated geographic sequence, affecting facilities from west to east across 4 countries in less than 17 minutes. Healthcare emergency coordinators across Western Europe initiated crisis protocols. The physical supplies remained intact in their warehouses. No medications had been stolen, no equipment had disappeared. But the databases that enabled rapid emergency deployment had been corrupted to show supplies that didn't exist or hide resources that were actually available. The World Health Organization Regional Office for Europe activated its Emergency Supply Coordination Center. What looked like scattered data quality problems was revealing itself as systematic sabotage. Strategic reserve databases weren't experiencing random errors. They were being deliberately falsified. Every modern healthcare emergency response depends on accurate inventory data to deploy the right supplies to the right locations during crises. When databases show phantom inventory, emergency responders make deployment decisions based on false availability, creating dangerous gaps during actual crises. When databases hide real inventory, critical supplies remain unused in warehouses while healthcare facilities face shortages. Technical teams began reconstructing the attack timeline. The database manipulation had been active for at least 33 hours before the simultaneous discovery event made the pattern visible. During that period, inventory records had experienced progressive corruption that appeared consistent with data quality degradation or software bugs. The attackers had been testing system vulnerabilities, introducing graduated falsification to map how inventory systems reacted, and what corruption levels would remain undetected during normal operations. Analysis teams identified the attack methodology within 10 hours of full alert status. The operation had exploited network vulnerabilities in cloud-based inventory management platforms used by multiple national reserve systems. Many healthcare authorities had migrated their strategic stockpile databases to commercial cloud services for improved accessibility and disaster recovery. The attackers had compromised these cloud platforms and deployed malicious code that progressively corrupted inventory records, while maintaining database integrity checks that would normally detect such errors. The technical analysis revealed alarming sophistication. Rather than simply deleting records or randomizing quantities, the operation introduced logically plausible but strategically dangerous falsifications. Inventory quantities were inflated by factors of 10, 100, or 1,000. Large enough to create deployment failures, but plausible enough to pass cursory review. Expiration dates were extended by months or years, hiding supplies that had actually degraded. Equipment locations were shifted to facilities that existed in database records but had been decommissioned years earlier. If the operation had continued undetected for another 21 hours, it would have intersected with a scheduled large-scale emergency response exercise involving deployment of pandemic supplies to 340 hospitals across the region. The exercise protocols required healthcare facilities to request specific quantities of protective equipment, medications, and medical devices from strategic reserves. With corrupted inventory databases, the deployment would have failed catastrophically. Facilities requesting supplies that databases showed as available would have received nothing, while actual available supplies in misdirected locations would have remained in warehouses. The cascade modeling revealed the scale of what had been narrowly avoided. If an actual pandemic or mass casualty event had occurred during the database corruption window, healthcare systems serving 280 million people would have attempted to activate emergency supplies based on false inventory data. Hospitals expecting 89 million medication doses from strategic reserves would have discovered those supplies didn't exist. Emergency medical teams deploying to disaster sites with promises of 14,000 ventilators from stockpiles would have found empty warehouses or decommissioned facilities. The consequences extended beyond immediate supply shortages. Healthcare surge capacity planning depended on accurate knowledge of strategic reserve availability. Hospitals made staffing decisions, postponed elective procedures, and allocated critical care beds, based on assumptions that emergency supplies could be deployed if needed. False inventory data would have invalidated these carefully planned surge protocols, forcing healthcare administrators to improvise crisis responses without the safety net they believed existed. Public health emergency protocols represented another critical vulnerability. Pandemic response plans assumed strategic reserves could provide protective equipment for healthcare workers within 48 hours of activation. With corrupted databases showing phantom inventory, the deployment timeline would have collapsed. Healthcare workers lacking proper protection would have faced impossible choices between abandoning patients or risking infection. Exactly the scenario strategic reserves were designed to prevent. Mass casualty incident responses faced compounded challenges. Major disasters, terrorist attacks, industrial accidents, natural catastrophes generated immediate surges of trauma patients requiring specialized medical equipment. The falsified inventory would have shown ventilators, surgical supplies, and critical medications available for deployment when warehouses actually held different items or empty storage locations. The deployment failures during the critical first hours of mass casualty response could have determined survival outcomes for hundreds of victims. Pharmaceutical supply continuity depended on strategic reserves as backup during commercial supply disruptions. The 89 million medication doses in strategic stockpiles included antibiotics, antivirals, and emergency treatments that might become suddenly necessary during disease outbreaks or bioterrorism events. Database corruption hiding these supplies or showing false expiration dates would have prevented their deployment when commercial pharmaceutical supply chains couldn't meet emergency demand. The National Security Agency had been tracking the cloud platform intrusion since 1845 UTC on the first day. More than 18 hours before healthcare authorities recognized the coordinated pattern. The initial detection came from network traffic analysis, identifying unusual data modification patterns to healthcare inventory databases. The access signatures matched previous supply chain attacks but demonstrated enhanced sophistication in targeting strategic reserve systems specifically. Within 8 hours, NSA analysts had mapped the complete intrusion architecture, identified the compromised cloud platforms, and begun coordinating with European partners on data recovery strategy. The challenge wasn't just stopping the database corruption, it was determining which inventory records were accurate and which had been falsified. The attackers had designed their corruption to be subtle enough that distinguishing real from false data required extensive cross-referencing with physical inventory counts. The recovery operation began at 0450 UTC. Cybersecurity teams worked with healthcare authorities and cloud service providers to isolate compromised databases, restore clean backup copies, and implement emergency access controls. The approach required careful validation. Each inventory record needed verification against physical warehouse counts before the database could be trusted for emergency deployment decisions. Rushing the restoration could reintroduce corrupted data that would create new deployment failures. Healthcare authorities simultaneously initiated emergency physical inventory audits across all affected facilities. Warehouse staff counted millions of items: protective masks, gloves, medications, ventilators, surgical supplies, to establish ground truth that could verify or correct database records. The manual counting process required mobilizing hundreds of personnel and consumed 47 hours of intensive effort across 64 facilities. The database restoration took 112 minutes to isolate corrupted systems and restore backup data. However, full verification of inventory accuracy required the 47-hour physical audit to complete. During this validation period, strategic reserves remained technically available but couldn't be reliably deployed because inventory data remained uncertain. Healthcare emergency coordinators developed contingency protocols for responding to crises without confirmed strategic reserve support. Forensic teams analyzed the intrusion methodology and malicious code recovered from compromised cloud platforms. The attack had exploited authentication vulnerabilities in cloud service provider systems, gaining administrative access that allowed manipulation of customer databases without triggering standard security alerts. The attackers had maintained persistent access for at least 42 days before activating the inventory corruption, using that reconnaissance period to map reserve systems and identify optimal targets for maximum disruption. By 72 Zone UTC from initial discovery, Western European strategic reserves had returned to verified operational status. Healthcare authorities issued security advisories regarding enhanced database monitoring and accelerated migration to more secure inventory management platforms. Emergency response agencies reviewed their verification procedures for strategic supply deployment. The immediate crisis had been contained, but the vulnerability remained. The investigation revealed additional troubling details. The database corruption had been designed with escalating severity. If initial subtle errors weren't detected and corrected, the falsification would progressively worsen over weeks. The automated escalation suggested the attackers had studied strategic reserve management extensively and understood how to gradually degrade data integrity without triggering immediate audits. The activation timing, mid-month before scheduled exercises, was clearly chosen to allow corruption to accumulate and create maximum impact during planned emergency response tests. The geographic targeting showed strategic understanding of European healthcare emergency architecture. The affected reserve facilities represented critical nodes in multinational medical surge networks. Corrupting these specific stockpiles would cascade through coordinated pandemic response plans that assumed cross-border resource sharing during major health emergencies. The 21-hour window before the exercises represented the operational time frame needed to demonstrate catastrophic failure of strategic reserve deployment. The operation also highlighted cascading vulnerabilities in emergency preparedness systems. Strategic reserve failures don't just affect immediate supply availability, they cascade through interconnected response protocols. Healthcare facilities lose surge capacity confidence. Emergency managers question pandemic response feasibility. Public health authorities face political pressure about preparedness investments. The psychological impact of demonstrated reserve system vulnerability extends beyond any physical supply shortages. European health authorities and the NSA conducted extensive analysis of the attack methodology and intrusion patterns. The technical fingerprints showed innovations beyond previous healthcare system attacks, specifically the subtle inventory falsification designed to evade detection, and the sophisticated understanding of strategic reserve operations required to corrupt data in strategically meaningful ways. This suggested either capability advancement by known threat actors or new operators with specialized expertise in healthcare emergency logistics. The incident triggered comprehensive reviews of cybersecurity and strategic reserve management. Healthcare authorities accelerated deployment of enhanced database integrity monitoring and multi-factor authentication for inventory system access. Cloud service providers implemented additional security layers for healthcare customer databases. Emergency response agencies updated their protocols to include regular physical inventory audits that could detect database corruption. But the fundamental vulnerability persisted. Strategic reserves would continue to depend on digital inventory systems to enable rapid emergency deployment. The database complexity required to track millions of items across dozens of facilities created attack surfaces that sophisticated actors could exploit. The cloud platforms necessary for accessible inventory management provided network pathways that determined attackers with sufficient operational patience could compromise. The behavioral analysis revealed concerning operational characteristics. The 42-day reconnaissance period demonstrated patience exceeding typical cybercriminal activity targeting healthcare systems. Most attacks sought immediate ransomware payments or patient data theft. This operation showed different characteristics: prolonged observation, careful corruption of operational data, and timing coordinated with emergency exercises to maximize strategic impact rather than immediate financial gain. Geopolitical analysts noted strategic implications of healthcare emergency system vulnerabilities. Strategic medical reserves represented critical capabilities for responding to pandemics, bioterrorism, or mass casualty events. Demonstrating ability to corrupt these systems undermined confidence in emergency preparedness and created uncertainty about healthcare surge capacity during the exact scenarios reserves were designed to address. Public health research institutions examined the incident through the lens of pandemic preparedness. Recent disease outbreaks had highlighted the importance of strategic reserves for protecting healthcare workers and maintaining medical system functionality during surges. Evidence that reserve databases could be systematically corrupted created concerns about resilience during actual emergencies, when supply deployment failures would cost lives rather than create exercise embarrassment. Healthcare economics analysts assessed financial implications beyond immediate incident costs. The database corruption had required emergency physical inventory audits, consuming significant personnel time and resources. The verification delays had prevented scheduled exercises from proceeding, wasting planned training investments. The long-term costs included enhanced cybersecurity requirements and redundant inventory verification systems that strained healthcare budgets already stressed by competing priorities. Medical professional organizations expressed concern about implications for healthcare worker safety. Nurses, doctors, and emergency medical personnel depended on strategic reserves to provide protective equipment during infectious disease outbreaks. Database corruption that prevented equipment deployment would force healthcare workers to provide care without adequate protection, creating moral dilemmas and occupational health risks that could affect workforce retention during future emergencies. Emergency management community analyzed the incident as a case study in critical infrastructure interdependencies. Strategic reserves supported not just healthcare but broader emergency response, providing supplies for disaster response, supporting mass evacuation shelters, enabling continuity of essential services during crises. Database corruption affecting these multi-purpose stockpiles created cascading vulnerabilities across emergency management domains. Cybersecurity insurance industry reviewed coverage implications for healthcare cyber incidents. Standard policies addressed data breaches and ransomware but didn't explicitly cover inventory database corruption affecting emergency response capabilities. The demonstrated attack methodology required new policy frameworks addressing operational disruption risks in healthcare emergency systems. Technology vendors specializing in healthcare logistics began developing enhanced inventory systems with corruption resistance. These platforms implemented blockchain-based audit trails, continuous physical inventory verification, and anomaly detection algorithms designed to identify systematic falsification. Implementation required substantial investment in new infrastructure that healthcare authorities struggled to prioritize against direct patient care needs. International health security frameworks incorporated lessons about strategic reserve vulnerabilities. The World Health Organization updated guidance on emergency stockpile management to emphasize cybersecurity requirements and verification procedures. However, implementation remained variable across countries with different resource levels and competing health system priorities. Pharmaceutical manufacturers examined implications for their role in emergency supply chains. The reserve database corruption highlighted vulnerabilities in coordination between public stockpiles and commercial production capacity. Hospital preparedness coordinators reviewed their emergency operation plans. Healthcare facilities had developed surge capacity protocols, assuming strategic supplies could augment their limited inventory during emergencies. The database corruption forced reassessment of these assumptions. Biodefense specialists noted implications for preparedness against biological threats. Strategic reserves formed a critical component of bioterrorism response capabilities. Database corruption preventing deployment during actual attacks could result in mass casualties that proper stockpile access would have prevented. Supply chain security researchers identified the attack as exemplifying threats targeting logistics information systems rather than physical infrastructure. Modern threats increasingly targeted the coordination systems, achieving strategic effects without physically touching the resources. Budget authorities faced pressure to increase emergency preparedness funding. The incident demonstrated vulnerabilities requiring investment in enhanced cybersecurity and redundant inventory systems. However, healthcare budgets remained constrained by competing priorities. Academic medical centers incorporated the incident into training curricula. Medical students and emergency management courses began including case studies about strategic reserve vulnerabilities and the importance of verification procedures during crisis response. International humanitarian organizations examined implications for disaster response. Many developing nations depended on international strategic reserves during health emergencies. Database corruption affecting these shared reserves could prevent deployment during crises in vulnerable populations. The systems remained stable. Inventory databases tracked their millions of supply items. Warehouse management systems coordinated stock rotation and expiration monitoring. Emergency deployment protocols maintained readiness for crisis activation. The 280 million people protected by Western European strategic reserves went about their daily lives without awareness of the database vulnerabilities that could have prevented life-saving supplies from reaching hospitals during their moments of greatest need. Everything worked normally, until the moment it wouldn't.